Welcome to UroChannel. This video is part of a series dealing with sexual function in spinal cord injury and neurological disorders. My name is Stefan Buntrock. I'm a board-certified urologist and sexologist, and if you are new to UroChannel or haven't watched the first episode, you should stop here and do that first, because it will be difficult to follow along if you have no idea about the anatomical foundation. When it comes to erections, there are basically two kinds: psychogenic and reflexogenic erections. Psychogenic erections occur from erotic thoughts, watching erotic material, being in an erotic situation, and so on. This type of erection is mediated by sympathetic pathways which exit the spinal cord at T10 to T12. If the spinal cord is damaged above this level, psychogenic erections will be lost, as the signal is unable to pass through the damaged area. If psychogenic erections are possible or not may also vary quite a bit between individuals. Among other things, it depends on whether the lesion is complete or incomplete. So they might be possible nevertheless, but then they are mostly only weak and not firm enough for intercourse. But patients who have lesions above T10 have a good chance of retaining reflexogenic erections. These are erections resulting from touch to and stimulation of the penis. This is possible because reflexogenic erections are mediated through a local sacral reflex arc at the level of S2 to S4. Generally, one can say that men with spinal cord injuries at the upper end are more likely to retain some kind of erectile ability. Once again, patients with incomplete lesions are usually better off than patients with complete lesions. Generally, the risk of erectile dysfunction after spinal cord injury is very high. Roughly 3/4 of the affected will have erectile problems. These are more severe in lower spinal cord lesions, especially if the cauda equina is involved. This is because reflexogenic erections will no longer be possible because the sacral reflex arc no longer works. However, psychogenic erections may still occur in these patients. Overall, the quality of the erection often is no longer the same. They may be of short duration and with insufficient rigidity. Reflexogenic erections may also occur at inconvenient times and cause embarrassment, such as when a catheter is changed or during cleaning of the genitals by nursing staff. There are some tools to help work around the erectile problem. Vacuum constriction devices and constriction bands, so-called cock rings, will help to keep the penis erect. Vacuum pumps work by pulling blood into the penis and make it erect. These are cost-efficient devices which are easy to use once proper technique has been established. Another possibility are Viagra or Cialis, so-called PDE5 inhibitors. They work by blocking an enzyme that is responsible for terminating an erection. So erections become stronger and will last longer. Another alternative consists of injecting a special type of medication directly into the penis. There are several formulations available. In the US, Trimix is often used. In Germany, we mainly use Alprostadil. Injection therapy is very effective and easy to use after proper instructions by the doctor in charge. In theory, Alprostadil can also be applied as a urethral suppository, so-called muse, but it has been unavailable for some years now. I am not sure whether it will return to the market. Then there is also a surgical solution with a penile prosthesis. The cavernous bodies are removed and 2 inflatable tubes are put in place. There is a reservoir filled with liquid which is placed in the lower abdomen, and a small pump is placed in the scrotum. The prosthesis works by inflating the tubes by using the pump. This is it for erections. In the next video of this series, I will talk about ejaculation in spinal cord injury. Thanks for watching. Bye-bye.